Okay, good afternoon, everyone. I'm going to ask people to get settled in the room. Wonderful. Oh, it's like a kindergarten class. You all got quiet very quickly. Thank you. Good afternoon and welcome. My name is Julie Donahue. I'm the chair of the Department of Health Policy and Management in the University of Pittsburgh School of Public Health. It is my pleasure to welcome you all to today's Sonis lecture. This event is sponsored by the family of Ann C. Sonis, the Department of Health Policy and Management, UPMC's Wolf Center, and UPMC Health Plan. And the Sonis Lecture is our major event each year that focuses on patient quality and safety. I am thrilled to welcome this year's speaker, Dr. Vincent Liu, Chief Data Officer at the Permanente Medical Group and a Senior Research Scientist at Kaiser Permanente, Northern California. Vinny, we've had over 400 people register for today's event, both in person and online. So I can tell there's a lot of interest in hearing what you have to say. This year's event would not have come together without the tireless efforts of our organizing committee, including Mike Friend, Cindy LeBerry, Dawn Ekus-Beam, and Gina Snyder. Please join me in thanking them for their efforts. I am delighted now to turn things over to Dr. Rachel Sakrowitz, who is going to introduce our speaker. She is an associate professor and executive vice chair in the Department of Critical Care Medicine at the University of Pittsburgh. In addition, she serves as the vice president of clinical resource utilization and operational excellence at UPMC. In these roles, she is leading a system-wide quality improvement effort on sepsis care. Thank you, Rachel.
Thanks, Julie. So good afternoon, everybody. I'm delighted to welcome you, re-welcome you to the annual 2024 Ann C. Sonis Memorial Lecture, which is part of the Dr. Lauren Roth Quality and Patient Safety Speaker Series. As Julie mentioned, today's event is co-sponsored by the Wolf Center at UPMC, the University of Pittsburgh Department of Health Policy and Management, and the UPMC Health Plan. So this afternoon, it's my distinct pleasure to introduce our guest speaker. Dr. Vincent Liu is a pulmonary and critical care medicine physician, a senior research scientist, and the regional medical director of the Augmented Clinical Intelligence Program for the Permanente Medical Group. He is a widely recognized expert in applied informatics, including the use of EHR data, machine learning, predictive analytics, and health system implementation. Dr. Liu has authored numerous scholarly articles on diverse topics related to sepsis, healthcare delivery, and artificial intelligence. He holds board certifications in internal medicine, pulmonary diseases, critical care medicine, and clinical informatics. And in addition to his medical degree, he also holds master's degrees in health services research and biomedical informatics from Stanford University. Dr. Liu's work spans the intersection of sepsis, acute severe illness, informatics, and healthcare delivery, with the goal of building a learning health system where science, informatics, and culture are aligned for continuous improvement and innovation. Today, he'll share lessons learned from a large health system approach to improving sepsis care and explain the role that artificial intelligence may play in enriching a learning hospital system. So without further ado, and I'm sure all of us are humbled and exhausted by hearing of all of Dr. Liu's accomplishments. Please join me in welcoming him for this talk.
Thank you very much. It's an honor to be here and also to enjoy this wonderful weather. I left rainy, snowy Northern California, and so this is like a little vacation for me. But you know, I've had the chance to meet with many faculty and QIPI staff, health services researchers, and leaders, and it's just been amazingly rewarding to see kind of the kinship that we have about using data and other levers that we have in a health system to improve the way that we deliver care. I'm going to talk a little bit about lessons that I've learned from a health system perspective, spanning from sepsis to a little bit of AI. And hopefully this will resonate with you in terms of the way that we can design and build our health systems to learn even faster into the future. Here are some of my funding disclosures, which I'll talk a little bit about different aspects of this work today. So I'm going to start with a scenario. So play along with me. As a doctor and patient, the doctor says, we're checking lab tests and imaging, giving you antibiotics. We're also giving you medications for sleep, blood clots, bowel movements, fluid balance, and pain. Thank you, doctor. That's really a lot. It's reassuring to know you're using the most up-to-date science to help me feel better. Well, yes, there is science and a lot of practices that are handed down through training. We call it the art of medicine. Do you mean art like the way my grandson draws a family picture in class? Well, yes, treatments are at the discretion of each doctor's experience and discretion. You're all expert artists, but you're also using science to learn more about how to treat me, right? We are doing our best, although there is a high chance that most of what we're doing for you in the hospital will never be studied in a way that actually provides a clear answer on what to do for patients like you. Oh, I see. Wow, it's incredible to think that you've never seen another patient like me. Oh, no, actually, we see thousands of patients like you every day across the country. So you mean in a couple years, you'll be able to improve on the treatment? I see that. Well, not exactly. We actually don't have a way to quickly learn from that information, and we may not know for my entire career. I think I'd like to be admitted to another hospital. Oh, I understand, but it's probably going to be the same or worse over there. So if you have an uneasy feeling about this, you might want to quibble with me about this, but the unfortunate reality is that as we approach our patients in the hospital setting, we feel a little bit like this today. We're both under-equipped to understand how to apply specific treatments to individual patients, as well as underprepared to learn in a systematic way into the future. And I think, when we think about a typical patient in the inpatient setting who may have 50 or 100 orders placed during admission, I've gone around the country asking what percentage of these decisions is based on high quality evidence. And I won't ask you to shout it out, but it's ranged from single digit percentages to something like 80%. So there's a lot of heterogeneity and maybe disagreement about how much we know. But more importantly, and perhaps even more staggering than that, is the question, in 5 or 10 years, what do you anticipate that percentage to be? Will we be further along in the process, or will we be at a similar state? And I would argue that this is a moral imperative of all of us. Not to be satisfied with the place we are today, but to stand up a systematic structure so that in 2, 5, and 10 years, we have a plan to learn, to be not wasting patient data as it flows in millions of items of ones and zeros across our hands today, but to use that in a systematic way. And that's very much been kind of the objective of national groups, including the National Academy of Medicine, as written about in a series of meetings and reports that occurred in the middle 2000s. So in 2007, when they published this volume called Learning Healthcare System, they said, our vision is a healthcare system that draws on the best evidence to provide the care most appropriate to each patient, emphasizes prevention and health promotion, delivers the most value, adds to learning throughout the delivery of care, and leads to improvements in the nation's health. And they set out a very tangible goal, which was this: by the year 2020, 90% of clinical decisions will be supported by accurate, timely, and up-to-date clinical information and will reflect the best available evidence. We feel that this presents a tangible and feasible focus for progress, that Americans ought to expect at least this level of performance. And I think, again, most of us, believe that we have not reached this 90% of clinical decisions, and we don't have a clear pathway to get there. Now, this is a figure from that original publication, which I turn to again and again. And even in our conversations that we've had over these past couple of days, continues to lay out, I think, the foundations of what it would look like to get us there. And so this is the learning healthcare system in just one simple diagram. And we focus on three major nodes: science, evidence, and care. And when we're doing this effectively, there's a virtuous cycle as we move across these arrows. And there are sciences that are undergirding these transitions between these nodes. So maybe it's the basic and translational sciences and clinical trials that gets us from science down to evidence, the knowledge or the proof that interventions are efficacious when we use studies of the most rigorous design, to move from evidence to care, to then apply those learnings to the large population of patients who are crossing through our doors. It's delivery and implementation science, and we've seen a large amount of activity over the past 10 or 15 years in this domain. But it can't end there. The promise of the learning healthcare system is that we slingshot ourselves around care in order to now re-enter this cycle of science, evidence, and generation a little smarter than where we were before we started. And as to what that science is called, is it self-learning science? Is it learning while doing? I think that should be the aspiration of the way that we design and implement the directives of kind of our healthcare system, at least in part, over these next 10 years. What is the workforce? What is the infrastructure? And what are the tooling that we need to propel ourselves to this virtuous cycle of learning? Now, there's three other elements that I want to draw your attention that are often hidden in this diagram. So the first is that underneath the arrows are ones and zeros, and I don't know if you can see that well, but data, having reliable, robust, available data smooths our path through this set of nodes. And so, that's been a huge focus of my career, is trying to get us to a better place when it comes to our use of data. I will also emphasize people. So that is our patients, clinicians, and communities, because as I'll talk about, and as we've talked about over these past couple of days, culture is a massive and important part to realizing and driving the change that we need. And then finally, at this outer loop, so this entire system is steeped within culture, incentives, and leadership. And that gets to, do our leaders buy into this vision? Do they set up the systems to incentivize us to move across this circle and learn? And again, back to the element of culture, how important that is. Even if we had everything else right, if we don't share the right learning culture, unfortunately, we will find ourselves having invested a huge amount with little to show for it. So I joined KP 12 years ago. I didn't know it at the time, but really to chase this dream of building towards a learning health system. So I put it up here. Kaiser Permanente exists to provide high quality, affordable healthcare services and to improve the health of our members and the communities we serve. Across the country, we have 12.6 million patients, about 23,000 physicians. Much of my work is focused in Northern California, and I'll talk about that today. This just gives you some of the statistics about the scale of our operations: 100 million prescription filled, 1 million mammograms a year, 700 million visits to kp.org. My guess is that the metrics from here are very similar or maybe even larger than these. But to show you all, which we have no shortage of data. Maybe it's locked away in the places that we can't use it. Maybe it's not semantically interoperable today, or maybe we don't have the workforce to draw insight from it. But again, when we speak to kind of the moral imperative we have to use those data to improve care, it's not for the lack of data that we find ourselves stymied today. But it is not only another reason that I joined KP was because big data is in our DNA. And this is the obituary of the founder of the division of research where I've done most of my research, Morris Collin. And this is from his obituary in the New York Times when he died at 1,000. But he was kind of one of the founding leaders in the field of clinical informatics. And in this second paragraph, it says, by the early 1970s, with the help of federal funding, the database that he was building had grown to hold information on several million patients, becoming a valuable tool for tracking individual cases, but also for identifying broad trends. And the way that both he and our founding physician, Dr. Sidney Garfield, approached the use of data, proactive collection, systematic kind of interoperability or understanding, and then using that to inform the way that we deliver care, that theme has just echoed through all of the work that I do and the aspirations I think that we all share about how we use data to inform care. So when I joined KP as a young researcher, I was looking for an area of research to get engaged in. And although these days sepsis has become one of those areas that I have published a lot in, it was an area I desperately did not want to research. I thought at the time, this is 2011, sepsis was played out. Everything had been done. We knew what we knew. And I was looking to, find something else in critical care. But in fact, I got sucked into sepsis. And again, it was because it was a massive healthcare system problem for us and an area of great focus and attention. And so, I kind of, came to be part of a team that was helping us organize ourselves around the way we approach sepsis care. So this is an older slide. This is actually from, I think, about 2016 or 17. But, sepsis remains a matter of public health. It is common, costly, and deadly. Statistics from that time suggested it affects 1.5 million Americans and 30 million people worldwide annually. Dr. Christina Rudd and others from this group and from the Global Burden of Disease, of course, have published that it contributes to as much as 19 to 20% of all global deaths each year. It's associated with U.S. healthcare costs of $20 billion each year. That's far higher now. Is a factor in at least 1 in every 3 hospital deaths. Results in long-term functional and cognitive decline. Again, researchers from UPMC showed that it is one of the most common reasons for rehospitalization. And at the time, and even today, is poorly recognized and understood by the public. But not only that, the leaders at KP had undertaken a deep dive or a mortality diagnostic in right around the time that I was just getting to KP in order to understand what was driving mortality in our hospitals. So this is what they asked our teams to do at our 21 hospitals in Northern California, review the last 50 deaths. So a convenient sample, and then hand code the reason for mortality. And what they did was then convened all of the leaders from our hospitals. And in that examination, they found that sepsis was a contributor to somewhere north of half of all of the deaths in the hospital. And that's what spurred them to take this first kind of big step towards improving sepsis mortality. Now, you probably have something like this, that talks about the multidisciplinary aspects that are needed to drive quality improvement, performance improvement, or change management. But it's some combination of teams, tools and equipment, algorithms, handoff and communication, training and education, and then measurement and PDSA. And one of the earliest lessons, and that shaped my career from our quality leader at the time, Dr. Lan Whippy, was really this slide, which is that we need a car that drives us towards our destination, where the 4 wheels are leadership alignment, standardization, project management, and data. And that's really been kind of where I focused my career. A phrase that I shared with some of you is data that drive, right? data that are not just meant to be published in a paper, although that's a great achievement, but data that are meant to be at the fingertips of a decision maker to make the most insightful and impactful decision. So I came on as they were already in the midst of this process, and they did a bunch of things. I'll show some graphs here. This is a little bit busy, but just focus on the blue line. And this is over time from 2002 to 2013, where the red line there is when the sepsis programs start. But what they did was simple things, like they took the lactate tube, which a lactate is a measure of severity of illness that's used to risk stratify patients. And they just, for every lactate tube, they rubber banded it to the blood culture bottles. Simple interventions, they don't involve some fancy AI. But what that did was change the collection of this risk stratification tool from an average that were being collected of under 5,000 a year to nearly 43,000 a year. And that became part of the basis of a lot of the data that drove, understanding how we risk stratify our patients, understanding how we protocolize decisions around this element. At the time, the gold standard for treating sepsis patient was something called EGDT, early goal-directed therapy. This was work that was published in the year 2000 from Manny Rivers, which described a process of a very highly protocolized approach to resuscitating patients with sepsis. And so that was what they implemented. And it was a tough bundle of things to implement, because it included putting a catheter in the neck and a special one that had a special sensor, or taking lab values, and then a very rapid and condensed approach that involved many team members to give antibiotics, to give fluids, sometimes give blood transfusions and other things. But you can see that between 2009 and 2011, as they rolled out this vehicle for standardization and data, and then implemented within this multidisciplinary workflow, we could see rapid increases in bundle compliance. And I think that, similar programs exist in many places that show, tracking of these process outcomes. The EGDT implementation successfully produced mortality improvements. So this is kind of an older slide, and I'll show some newer slides later, but showing that as far back as 2006, when we risk adjusted patients according to models that considered severity of illness, including vitals, laboratory values, and other demographic and clinical characteristics, mortality had largely been stable for some time in these patients. But following the first sepsis summit, which was like about a 300-person gathering of people all across Northern California, in order to educate and standardize workflows, we began to see improvements in mortality. So everybody was really buoyed by this success, and very much excited about the changes that were happening. But it wasn't the end of this story, because the questions began to arise. So, for example, among the EGDT eligible population, mortality rate was high. It was somewhere around 23.3%. But when we examined the percentage of all sepsis deaths across our system that were happening, it only accounted for 23% of the deaths. And so it quickly became a question, how do we treat the rest of these patients who are dying from sepsis, but in whom there are no guidelines, right? And there are no randomized trials, no other evidence to help us understand how we should next take it to the second stage and try to drive mortality incidence lower. So, and in particular, because I mentioned that lactate had become a focus of risk stratification, we became focused on this question of intermediate lactate. So patients who were not as sick as those who were eligible for EGDT, but those in whom there was no guidelines. And so, the mortality rate in these patients was lower. It was only 8.9%. But when you looked at the large volume of patients coming in, they still contributed to even more deaths for intermediate lactate. And so this is kind of where I cut my teeth on asking operationally relevant questions on a very compressed timeline, because the health system wanted to act, but it needed some support to understand whether the decision appeared, at least in some analysis, to be justified. Now, fortunately, because as I said, big data is kind of in our DNA, I was able to pull together a cohort of 9,000 patients, which was far in excess of, the prior studies, which had largely been, at a smaller single center, or those that were collected manually, maybe in some prospective studies, and then use those data to help examine different aspects of bundle care. And, this graph is probably a little bit too detailed. But what we did was we used real world evidence to understand whether or not the principles from EGDT, which were largely earlier antibiotics and more aggressive volume resuscitation in patients with intermediate lactate, appeared to be associated with better outcomes. So here on the x-axis are increments of body weight adjusted fluid volume resuscitations that patients were given in a certain time period before they had their lactate rechecked, and then hospital mortality. And really, in a lot of the work, this number, 30 cc's per kilogram, in terms of 30 milliliters of volume given to patients per kilogram, was kind of an industry standard at the time. And so what this, again, pretty lightweight, relatively unsophisticated by today's standards, graph showed was that the mortality appeared to be in that kind of flat line, similar to the other groups. And so if we wanted to extend the similar types of process metrics forward, there was some justification to do so. Again, because we wanted to act, but we had a paucity of available evidence, this was what we substituted in its place, with the commitment that we would evaluate it, and evaluate it over a short term. And also with the commitment, because our clinicians were asking, what is going to happen to patients who are at risk of volume overload, right? So we want to give, you're telling us to give more fluids, to this target. So for an average size male, that's going to be, about 1.5 liters to 2 liters of intravenous fluid. So for a healthy person, really, they can tolerate it with no problem. But for a person who's already on the brink of having fluid overload from heart failure or kidney disease, we're very concerned that we're going to put those patients at greater risk. And so we said, well, over a short amount of time, because we're working in this kind of data evidence-free zone, we're going to evaluate this and also look at that subgroup. So what happened in 2011 and 2012, bundle compliance without any type of bundle education was about 33%. Mortality was between 8.8 and 9.3%. And after the bundle go live, bundle compliance only went to 45%. But we did see a substantial drop in mortality with, adjusted for a number of factors, of roughly a 20% decrease in adjusted mortality. Now, there are some really interesting findings here. We already had a mature sepsis program for the sickest patients, so people were very familiar with the concepts of sepsis. And yet, even with a relatively modest increase in bundle compliance, to a degree to which people wouldn't think normally it would drive improved mortality, we observed an improved mortality. So we felt good about, again, the justification of the evidence we were using, as well as the ability to quickly turn this around for clinicians. When we dug into this question about whether this was safe for patients, it kind of helped tell the story about this relatively modest improvement in bundle compliance. So on this figure, what I'm showing on the x-axis is the total amount of fluid that the patients received early in their hospitalization. And that's marked out at 0 all the way up to 6 liters in a kernel density plot. And then what I'm showing is in the solid line, the pre-bundle distribution of fluid administration. and in the dotted line, the post bundle, the 2013 fluid administration. And in fact, what we found was that among patients with no heart failure or kidney disease, clinicians on average were giving less fluid, less than the 2 liters and more in the 1 liter. And so that was a bit of a surprising finding. We were actually seeing less fluid administration in that group. But when we examined the patients who were at risk for volume overload, we saw the opposite. So again, where the pre-bundle administration is in the solid line and the post-bundle is in the dotted line, we saw substantial increases in the administration of fluids at 2 and 3 liters. And so we were changing the way we practiced. On average, it looked like a small increase, but when you broke it down by groups, there was differential changes in performance. And indeed, when we broke out mortality by those numbers, among more healthy patients, those without heart failure or kidney disease, there was actually no difference in mortality after implementation. And the mortality signal was being entirely carried by these patients who there had been fears about giving too much fluid. So, I think this was kind of one of the first health system evaluations I had the opportunity to participate in, and it taught me a lot about how we can use very up-to-date data, the best available evidence that we can generate from our own sample, a commitment to evaluate what we do over a short period, and then to listen to our clinicians to make sure that the parameters of safety that they're concerned about are at least addressed. And so, I think those, again, are some of the principles that we bring to this infrastructure for accelerated learning. Now, this is another figure that continues to show risk-adjusted mortality over time. The y-axis has changed a little bit because it's now pegged to more recent mortality. But you can see that we were already coming down off of the EGDT implementation. We continue to see ongoing decreases with our intermediate lactate bundle go live. And yet, we now hit a period of more than 2 years, 3 years of flat risk-adjusted mortality. And this, again, has taught me many lessons. And it's really important for us to understand together what this means, that there is going to be a plateau to improvement. There is a plateau to, even if you did sepsis treatment based on what we know today perfectly, there's a lower limit to what we can do with our available treatments and our available ability to risk stratify patients. And so the expectation is that we can't necessarily push harder. Once we hit a certain level of compliance, we can't flog our clinicians to give even earlier. What we need to think about are orthogonal or adjacent levers that we have in order to drive improved mortality. At this time, this is a slide from 2017. Lots of new studies had come out. EGDT had been essentially debunked, or it was no longer as relevant in the modern time as it had been. We participated with folks like Chris on, the international updated definitions for sepsis 3. There was a lot of data, again, from investigators here and elsewhere about New York State's implementation, the success that they saw. There was some compelling data from Africa about, a similar strategy that was deleterious among patients that were primarily HIV. And then CMS at that time was describing SEP1. So it became a question, what else can we learn? What are the channels that we can use our data to effectively make new decisions? And again, it came back to this, how can we use the data that drive in order to help us pivot? And I've spent now many years looking at every part of sepsis care that I can using this observational approach. And I'll just describe some of them here. post-sepsis utilization readmission, if we've hit a nadir in terms of the mortality that we can improve, well, what is the opportunity to mitigate the consequences of sepsis hospitalization after patients are discharged? And I think, there are, randomized trials here going on and other work across the world asking that question. We talked about sepsis 3, would improve definitions, optimize our data-driven approaches to defining sepsis, to optimize our care. Are there, what is the benefit of pushing our clinicians even earlier in terms of antibiotics? And what are the consequences of focusing on even, again, pushing antibiotics early? And for those of you who are in that QI, PI implementation space, you know that every percentage we gain in compliance comes with some increasing cost in terms of the effort we have to exert and potentially the resistance of clinicians to whatever we're trying to implement. Then a question about acute organ dysfunction. If we've reached this nadir, are there some organ dysfunctions that are more relevant to long-term mortality than others? How do we mitigate them? Questions about triage in the ED for borderline patients with sepsis. Is it better to put them in the ICU or to put them in the emergency department? And then finally, clinical heterogeneity in sepsis. Is there an archetypal sepsis patient, and how often is that patient present? And so I think what you can see here, this is maybe like when you look at an artist going through the phase of one painting to a new style. This is just rooting around, oh, this is interesting. Let me see. Is there something that we can mine here? And I will just say that we've published papers, we've gotten grants, there's ongoing work, no good answers. And maybe I will summarize where I think we are in terms of, yes, readmission is common and costly in sepsis. However, it's not clear to me that sepsis-specific approaches to readmission are more effective than broad-based hospital readmission approaches. And I would be glad to be proven wrong there. Sepsis definitions can help, but without a biomolecular gold standard for sepsis, something we still lack today, or component mechanisms that drive the pathology of sepsis, we're going to still propagate uncertainty. Earlier antibiotics are better. They don't seem to lead to population overtreatment. But there's work that we're doing that show that some patients benefit more than others from earlier treatment. In terms of acute organ dysfunction, we found that neurologic brain dysfunction had the greatest impact on long-term outcomes. And we're doing a lot of studies in cardiovascular disease, for example, looking at troponin elevations as a byproduct of sepsis and whether certain treatments in the hospital can reduce the long-term sequelae of cardiovascular disease. In terms of triage in the ED, we actually found that among borderline sepsis patients, admission to the ICU was associated with worse outcomes as compared to patients presenting with acute respiratory failure. And we have a grant with our colleagues at University of Pennsylvania to ask, to follow on and ask why. And then clinical heterogeneity in sepsis. There is no archetypal sepsis. There are phenotypes, but patients are coming in with symptoms and comorbidities all over the map. And we really need biomolecular targets, I think, to drive improved targeted treatments for these patients. So after a huge amount of work, rooting around unsuccessful inquiries into finding new insights that could, inform the way that we treat sepsis patients, I find myself asking, have we exhausted most of our opportunities in the inpatient space without novel diagnostic tests and or targeted treatments? And, I think this speaks to what the incremental improvement we're going to get from more and more efforts to, improve a certain process. Again, it's subject to the law of diminishing returns. There's a point at which we're getting very, 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 very little benefit. But in conversations with our clinicians, it got me thinking about whether or not we can actually prevent sepsis hospitalization in the first place. If we've kind of done what we can in the hospital, well, can we keep these patients out of the hospital? And this is a diagram of military assault rifle wound patterns, which essentially are exit wounds. The question that came into my mind, again, working in this integrated healthcare system, so having this larger perspective on our approach, can we move from the exit wound to the entrance wound, and then somehow to the projectile itself? And that's been an area of research for me that I'm still quite unsure about. So if we look at a trajectory from 7 days before hospitalization to the black box, which is hospitalization, and then what occurs after that, and on the y-axis is some simulated severity of illness of a patient. Most of the research up until about 5 years ago was really focused on this narrow window after a patient presents to the hospital. The kind of golden hours where we have our maximal opportunity to risk diagnose, risk stratify, and then treat patients. But we have, or we could have, potentially a long pre-sepsis opportunity to identify the patients as the simulated in severity of their infection and the associated systemic complications are still being manifested. The problem here is that we only have intermittent opportunities to observe patients, maybe in these red bars. So our capability to detect these incipient signs of impending sepsis are quite limited. And at the time, we didn't even know how many percentage of the time patients were presenting to physicians or other places before sepsis where we could intervene. And this is driven kind of a research program, where we had 3 major questions. Are patients using healthcare in the week before sepsis? And if they are, could these visits be used to alter their pre-sepsis trajectory? What symptoms are patients presenting with? And how early do they manifest before hospital presentation? Because if we can understand symptom profiles and pace, we can help define the window of opportunity for intervention. And then finally, if we were going to build a prediction model among these healthcare encounters, among any healthcare encounter, patient who shows up to clinic, what is the likelihood that given their clinical characteristics that they're going to end up in the hospital with sepsis over the next 7 days? And the reason we had to look at all encounters was because the way that this affects predictive modeling is it could lead to a lot more false positives. So in collaboration with colleagues like Hallie Prescott at the University of Michigan, we looked at patients where here on the x-axis, that's day 0, the day they get admitted, going back 7 days. What we showed that the number of ambulatory visits increased about 3 days before, and the fraction of diagnoses of acute infection also increased. We found that the use of antibiotics among patients who ended up in the hospital with sepsis also started to increase, maybe 3 or 4 days, and those prescriptions, that were filled. And what we found globally, which has been replicated, is about 50% of patients who ended up in the hospital with sepsis were seen by a physician in the 7 days leading up to sepsis. So I think what that showed us was there are opportunities to potentially identify these patients. With work done with Chris and Emily Brandt and others here, Chris Martin-Gill, we've been looking at utilization patterns. Where are they? Virtual care, ambulatory visits, ED, inpatient stays. And I'll just say that this is a mess. Patients are going every which way, and we have yet to identify kind of a clear pathway of escalation of severity or utilization. But this is an active area to understand the epidemiology of these patterns and thus to identify those time points where we can intervene. The other thing we did was, again, go back to our big data. So we pulled out patients with sepsis, infection, heart failure, and stroke, and we looked at their notes from the first 24 hours of their hospitalization. And we used natural language processing to look for what symptoms they were showing up with and how many days before they came to the hospital did we think that those symptoms started. This is quite a busy graph, but I will just say with heart failure in the third column, it was clear: dyspnea, cough, edema, chest pain, and orthopnea were the dominant symptoms. For stroke, it was weakness, altered mental status, hypertension, dizziness, trouble speaking, sensory losses, and facial droop. But when it came to patients with sepsis and suspected infection, what you saw was it was a smattering across many symptoms, with the most prevalent symptom being pain. So pretty nonspecific and, not enough to say to our clinicians, oh, if a patient shows up with infectious type symptoms, and it has pain, that should be a patient you should watch out for. But, beginning to try to unpack these, and in fact, the symptom profiles that patients had were very much associated with the type of treatments that they got in the hospital, which is not surprising. Here on the left, patients with fever were likely to get antibiotics the earliest, and patients with dizziness or chest pain were likely to get antibiotics the latest. Unconscious, hypotensive, and patients with respiratory failure, most likely to go to the ICU, as opposed to patients with dysuria. And then finally, what we've been doing is examining somewhere between 90 and 100 million visits in the ambulatory space, in the emergency department in the hospital, to understand the timing of incident sepsis hospitalization, as well as the percentages. They're pretty low. So from an undifferentiated ambulatory clinic visit, 0.2 to 0.3% of patients will show up to the hospital with sepsis in the next 7 days. And so that's not a shock, right? That's 2 out of every 1,000 of undifferentiated patients. But if we use simple clinical criteria like vital signs, we can actually enrich that population to about 5 to 7% in certain utilization patterns. And that informs the way that we've developed predictive models. Again, I won't go into huge depth here, except to say that we have built prediction models for determining from a clinic visit or an ED treat and release visit, whether or not a patient is at high risk for sepsis or suspected infection within the next 7 to 14 days. Some of these don't look great. For sepsis within 14 days, at a fixed ratio of 9 false positives for every true positive, the sensitivity is about 35% with a very high specificity. And so we're currently in this question and feedback generating cycle with our clinicians. Is this a tool that you could see even being tested in a pilot demonstration? What is the most clinically feasible and potentially effective tool? With the goal that in the future, we'll have tools like these running, whether that's machine learning or AI tool for initial risk stratification, that would be supplemented by screening workflows, biometrics, or diagnostic tests. And again, with the goal that probably the most effective way that we can reduce the adverse sequelae of sepsis is to keep a patient out of the hospital to begin with. And so, again, I'm unsure about whether we can do this. But COVID taught us that we can run a population health acute infection program that spans all the way from outpatient all the way to the ICU, that includes risk stratification, treatment, and diagnostic testing across all of those domains. So again, it's possible. It'll involve, a global pandemic worth of consensus building, I think, to achieve that. We also had other experience that, in fact, predictive models could drive improved outcomes. So this is an extension of the plot I had shown you before when we had that 3 years of flat mortality. And then we began to see decreases again. And so the question was, what were those? And it turned out they weren't directly sepsis relevant. So for a long time, it's been known that up transfers in the ward or clinical deterioration have an outsized impact on patients' outcomes in the hospital. So even though ICU up transfers, patients on the ward who go to a critical care unit only account for 3 to 4% of admissions, they account for as many as a quarter of all ICU days, as well as deaths. And many of these conditions might be preventable. Now, this was not a new finding. This is actually published in 1990 by Jose Escars in JAMA, where they looked at the predicted death rate among patients who went to the ICU from those three locations, ED ward or ICU, and then the actual death rate. And I've just included a ratio there. What the predicted death rate for a patient transferred from the ward to the ICU was only 38%, but it was 55%. So there's something happening to these patients while they're being watched on the wards, which represent a potential opportunity for us to identify them earlier and intervene. And that formed the basis for the work that myself and my mentor, Dr. Gabriel Escobar, had done to develop something called Advanced Alert Monitor, which is an early warning system, with these very patient-centered goals. Identify the highest risk inpatients, respect the patient's goals of care, because every patient who's deteriorating doesn't necessarily want more invasive treatment. So make sure we're doing what's aligned with their goals, give clinicians enough time for action, and then minimize false alarms for busy clinicians. We used at the time just what is now routine or simplistic EHR data, a bunch of labs, vitals, demographics. We used many of the channels that you have to use in order to implement change. So this is just a slide that shows kind of like a time scale for what the response should be. And what we educate our clinicians was, when you get this alert, walk, don't run, or you have you have time to finish your lunch, right? This is not something you throw everything off like a code blue, but this could happen as far as 6 hours out. We also had to do a lot of education because patients we found didn't like to hear an advanced computer system is monitoring you, or our algorithms show that your risk of requiring the ICU or dying is 18.4%. But, coming up with, kind of more patient-centered communication strategies. And then ultimately, I think you're all very familiar with things like this. I heard about it in the sepsis program. There's a whole schedule for how we implement this across sites. There's a lot of leadership meetings, readiness assessments, service line agreements, all the way out to education, workflow, and then ultimately implementation. And exactly over the period where we began to see new declines in sepsis risk-adjusted mortality was the period in which we were rolling out this alert in a stepped wedge fashion across 19 of our non-pilot hospitals, which spanned from 2016 to 2019. And it involved a huge kind of reworking of the system, funding for new rapid response nurses, lots of education, lots of out-the-elbow support, all of the elements that go into making a program like this successful. And we were delighted to see that among the target population, those in whom the alert was active at the time they were hospitalized, ICU admission was down, as well as death within 30 days, and there was no deleterious effect to the non-target population, other patients in the hospital. So this kind of has propelled a lot of the work that I do currently, which is this belief that if we can stitch together complex data a little bit earlier, we can arm clinicians with an ability to identify patients at high risk or to make their workload a little bit easier. Earlier, we talked a little bit about work that we had shown where we implemented a readmission risk score to target medium and high-risk patients and saw roughly a 10% decrease in risk-adjusted 30-day readmission or mortality. I talked a little bit about a randomized study that we put on after that used some heterogeneity of treatment effect to identify a low-risk population who would be most likely to benefit. But the work has gone on in many domains. Mike Kuznowitz and others put together a newborn neonatal sepsis risk calculator and showed that by implementing it, they could reduce blood cultures or antibiotics in the first days of life by more than 50%, with no deleterious effects of increased rates of sepsis among babies. Folks like Jonathan Volk and Mike Silverberg showed that an HIV pre-exposure prophylaxis model that used prediction of incident HIV infection could increase the rates of PrEP referrals, although there was differential in how effective it was. very, very effective among family medicine doctors that were primarily treating HIV patients, and not effective among those who weren't. So, implications for how we roll these things out. Folks like Vignesh Arasu are using computer vision in order to improve the way that we screen for breast cancer compared to traditional risk factors. So there's a large kind of pilot evaluation of mammogram screening where the computer vision can identify high-risk features even in mammos that are read as negative, with the estimate that we can improve the identification of the highest risk women from 35% today using traditional clinical risk factors to 75%. And then, extending this now into the age of AI. So Dr. Chris Lee, who's now my boss, has been running a program where we've been using NLP and large language models on all the messages that come to our physician inboxes. So this is a study of just 5 months of data, 4.5 million messages, and all of them are labeled in real time. And then the messages are sorted based on their labels. And so with this program, this shows you all of the different kinds of message labels that are attached to different regional level workflows. So for example, the most common is medications, but you can see there's emergent symptoms, there's blood pressure, COVID, et cetera. And with the pairing of this program of labeling with regional workflows, they were able to redirect about 1.5 million messages in real time to regional response teams who could resolve the message without it ever ending up in our physician's inbox. So, not full AI like a robot, but AI assisting, teams that could, rapidly help to offload the crazy amount of messaging happening out for our internal medicine docs. And then Aaron Tierney is an informatics fellow, and he led an evaluation of ambient AI, which is, a microphone that listens to patients and doctors talk, transcribes it, and then summarizes it to reduce the clerical burden of documentation. We did a 10-week evaluation here, which showed that, it had been used 300,000 times by our clinicians in patient encounters. And we did some evaluations like what is the quality of the note? When we used an instrument to grade, whether it was thorough, did it have hallucinations, was it free from bias, et cetera. We also examined whether it reduced, in fact, the clerical burden on our clinicians. And this is just one sample figure here. Using the tool actually appeared to be reducing note time that clinicians were spending in notes because, again, this technology is kind of seamlessly taking in this information, summarizing it for them, and then putting in the chart. Of course, we do know in this write-up that it was hallucinating as well. So it's not without its dangers. In one instance, they had talked about hand, foot, and mouth examination, and it said, oh, this patient has hand, foot, and mouth disease. Or, it would do things like that. But, again, I think there is tremendous potential in now using predictive modeling and AI to become more efficient and more effective in the way that we care for patients. Derek is participating with us as a national advisor on a program of research called AIM High, Augmented Intelligence in Healthcare and Medicine Initiative, in which we receive funding from the Moore Foundation to fund 5 external health systems to do randomized trials of AI and ML implementation in their systems, and kind of collecting those learnings, helping to support these groups, and hopefully to add to the evidence base about the use of AI and ML. I'm particularly excited because 2 of these are directly targeted towards federally qualified health centers to show that this technology may face different barriers at some of our more under-resourced health system partners, but that it hopefully will be successful in enhancing their care. I'm going to close by taking us back to this doctor and patient. For a typical patient who has 50 to 100 orders placed during admission, how do we ensure that each of these decisions is based on high quality evidence. And that's a question for all of you, all of us in this room, to understand how do we design, build, and execute on a system that gets us to that place in 2, 5, 10, or 20 years. I think there's still principles to learn for data, improving interoperability, building out more powerful computing platforms, using advanced techniques like causal inference, or leveraging AI, where it has transformational abilities to draw insights from data. I think clinicians and people are central to this process, making sure that there's adequate representativeness about the questions we're asking. There is engagement of our people, because they bear the brunt of the interventions that we are going to choose to deliver across the health system. And then teaching them and gaining their trust about novel study designs, because there's lots of really exciting approaches to the way we learn that are just becoming kind of more routine or more available over these past 10 years. And perhaps the biggest question is for our system. How do we steep such a system in the right culture, incentives, and leadership? Particularly, who is accountable for this learning? Who benefits from it? And then ultimately, who resources that work? And, hopefully, again, we get to engage in this, painstaking but transformational work of improving the way that we learn from each patient that passes through our doors today. Huge amount of people at KP to thank for contributions across all of these different types of work, without whom none of this would have been possible. And thank you for your time.
Fantastic. Good morning, Rick. We have microphones on either side of the room, and hopefully some questions online. But anyone in the room wants to pose a question or two to. Don't be shy.
Could I just ask the question you asked? Who is it? How would you incentivize? What's the model to get health business?
So I think that if such a system were more seamless, that it would become more valuable to our bottom lines and our business imperatives than it would be to even gaining generalizable knowledge. Like if we could get to a position where the value of this information was critical to annual decision making by our health system leadership, and then a byproduct of it would be fantastically important work that's generalizable. I think that is the way that we create a sustainable platform for this type of learning. That's challenging for many reasons. The competing priorities, disruptions in healthcare, the financial state of the overall system today, a lack of understanding about, this, the techniques that we do have available. And any number of those, I think, are barriers to that. But visionary leadership and trust, and then a system that works, I think, is our path forward.
So what do you think idea of collaborative learning? And Kaiser is well prepared to do a lot. Other systems are not. You got a national initiative.
Yeah, so obviously there's been a huge amount of excitement about AI, particularly as generated by Gen AI, because we've put a consumer-facing front on top of something that had just been growing over time. And again, I think people see this ground-shaking potential for this technology in hopefully mostly positive ways, but in some ways we need to guard against. There have been substantial concerns about the tools and what is produced from some of these things, because there's been evidence that they may be biased or lead to unintended consequences that disfavor some groups. There have been concerns about automation bias, the fact that clinicians or people in general will trust an automated system more than I think what's in front of their eyes. There are concerns about, is there adequate resourcing across the diversity of type of healthcare settings that these tools could be deployed in? So with the executive order on AI, there's been a huge amount of activity. One of those things has been the standing up of a group called the Coalition for Health AI, CHAI, which is a public-private partnership that, as far as their press release earlier this week, has signed up 1,300 organizations to participate in a national assurance network for AI. And the goal of this is maybe to be like the underwriter's laboratory, or some set of standards that allow a developer to externally test and validate the performance of their algorithm, and then lend an additional layer of credibility or the identification and mitigation of pitfalls in a standardized way. So that was literally just announced. I think that is it will help to create the frameworks for evaluation, especially in an area like generative AI, where I don't think anybody knows what a rigorous evaluation of safety is today. And if you benchmark today in a month, the whole thing may have changed. So I think that's going to be a big struggle. There's some other activities like the National Academy of Medicine AI Code of Conduct group, National Institutes of Standard and Technology, and then other regulations like the FDA's clinical decision support, software as a medical device, and other things. So there's a huge amount happening in this space. I think it's good. The creation of standards, the rules of the road, will help hopefully to accelerate the use of this technology. But there are a lot of gaps that remain, especially about local implementation. Like even if it's been validated in this in KP or UPMC data, does it work for my population where I am? And do my clinicians use it correctly? So there's a lot of monitoring that is going to be a part of this. So a lot to work out that is just beginning kind of right now. Yeah.
It's a question about the need between care and science.
Okay. With coming all these AI tools and these high dimensional data, do you believe that there is a time to shift the paradigm of the medical training as well as how we generate our hypotheses or not?
So I think the question was about medical training and the way we generate hypotheses. So it's like, what is the role for a copywriter going to be 10 years from now? I don't know. Or those of you who saw this tool, Sora from OpenAI, which can produce movie quality video based on a line of text. So what is the role of, cinematography? Like, is it going to go away? No. Is it going to be radically altered? Probably. And so I think we have to think about that for medical education or all clinical healthcare education. But I'm not expert enough to know, what to do there. So great point. As to hypothesis generation, I think there's this, I think if we could shift from only doing trials or studies in hypotheses that we generate to throwing away 98% of the hypotheses which are not founded based on a high throughput examination of data, what it will mean is it will open up more questions that are testable and answerable. And the total number of hypotheses that are compelling would increase on average. So does that answer your question? There's a shift there. People are pretty concerned about it, that it's just going to be garbage out. And so very reasonable concern. But I think there's tools and kind of flow charts we can work towards that will improve our capability to do that.
Dr. Liu, we have one from online, and it says, how do you implement the information to address physician resistance to the implementation of your data?
So I think we had a chance to talk a lot about this. Fundamentally, clinicians have to trust the leadership about why an implementation is needed. So that trust is built on a compact, an agreement that this is for the good of clinicians and patients ultimately. And so, and that from a population or a larger perspective, that's hard. Gaining that trust is very costly to gain and very easy to squander. So I think, unfortunately, there's no easy way around that. You can tie sticks and carrots to it, but, maybe that'll work for one program, not for 10 or 50 or, 50. And then I think, clinicians need to be assured that they have access to the data that are undergirding some of these efforts. So the ability to provide them with the data that show kind of a principled approach to the metrics that are being evaluated and what those are producing in outcomes, and hopefully a low latency way, I think is another tool that we have to help to support them. But it's trust, culture building, leadership, incentives, all of those tied together.
So you basically pointed out that in 2007, you were optimistic that you would get. 2007, you pointed out we were optimistic we could get to 90% in a decade or so. Here we are, fast forward, life expectancy is lower, more data available. What would you say is your level of hope at this point? And what do you think is better or different that gives you that hope if you have some? I would be interested.
That's such a hard question. So I'm an optimistic person. So I'm going to hold out hope that we'll have the leadership and the capability to do so. I think the capability is not far off. The statisticians, the data scientists, the healthcare domain experts, and the data itself are within reach. Not easily within reach, but they are actually available in a way that wasn't present in 2007. Like we've had a couple generations of advances in that whole domain of data infrastructure and statistical methods. I think this question about who is accountable and who leads, who takes the risk and invests, that's probably the hardest one. Like if the leadership is there, the tooling can be built, and I think and I think we'll see wins within 3 to 5 years. So it's a bit of my doubts are founded in the disorganized nature of healthcare, the financial pressures that we're under, and the consensus building we need to achieve this future.
Hello, I was curious about how patient the privacy is protected. So during the generative AI and the patients talking about maybe their families or things that are not relevant, does that information get sort of deposited into a database? AI is trained on it, or what happens to that?
Yeah, so I mean, in the pilot demonstration that I described, the data are kept, I think, for 7 or 14 days and then struck. from the record. So, and only the transcript is kept, not the audio file. Also some of the tooling around the summarization, tries to reduce or eliminate the summarization of the kind of extraneous features, from the text. So I think there's a long way to go in terms of customization to make sure that privacy is preserved. But I think in general, there have been reasonable approaches and tools that help us to preserve privacy here, if that makes sense, within the note itself.
And then if I could follow up on that,
Yeah.
does the physician feel like they have to pay extra attention to catch any errors? Or are they more like, or are they more likely to just sort of believe what AI had generated?
So we're undertaking like a pretty deep dive on quality. So every physician examining their own notes, doing some degree of QA. I think what we educate them, which is the same as for predictive models, which is the same as for labs. Like you have to treat the patient in front of you and you're, responsible for your documentation. You should expect that Gen AI will make errors in either the emphasis of what you want to bring to the summary, potentially have some hallucination. So ultimately, we're putting faith into our clinicians' hands that they will be able to, adequately provide trustworthy documentation. Yeah.
Got one more question on time. And one more question here. Okay.
Hi, Dr. Liu. Thanks for your time. This is more of an operational question about some of your earlier sepsis work early on in your career. So when you were launching some of those initiatives and bringing them online, did you find that you had the right resources already in-house to bring some of that up? Or did you find that you had to bring additional staff, additional talent, or other groups in to try and get some of that launched? Because from our perspective on the frontline side, the resource pool for pretty much everybody is very tight. So figuring out the best people to involve in that, whether or not we already have them here, is something that we've all been sort of dealing with. I would love your thoughts.
So fortunately, of that vehicle that I showed, I mostly focus on the data part, the data that drive, because the truth is implementation and change management at that scale it's an enormous task filled with lots of sleepless nights and resistance and difficulty. And so I would say there was QI and PI infrastructure, but when you're talking about an effort which is over a very compressed time frame, there are certainly additional resources that have to be brought to bear, because to justify the rationale, to educate, to be at the elbow, to provide the data that supports the intervention, all of those things are typically at a evaluation of the implementation of that scale, probably not available just within existing resources. Yeah, so I would say that's constantly a question, as I'm sure it is here. How do we prioritize each year or each 2 years what we can do, what we have the resources to do? And that's a prioritization question that's really, really challenging, because it seems like we should be moving in 50 directions at once, but the system can't sustain that much implementation and do it effectively.
Hi, one last question. Hi, Vinny. That was great. So you've shared at Kaiser how there's this compressed timeline on the implementation side, right? You have these resources you're talking about, and so the knowledge and science you're generating is getting to the clinicians pretty quickly. But since the generative AI or large language models are all built on data, how are you keeping things current? And does that not lose the clinicians? And in our talk before, we were saying, wow, there's new ways of diagnosing X or new criteria for this disease Y, but the model doesn't know that yet. So how are you approaching that challenge?
Yeah, I mean, that's a great question. I think the fact is, like, over the, 12 years that I've been doing sepsis related research, I mean, the landscape's changed every 2 or 3 years in a pretty dramatic way. Like much of which has been driven by you guys. So, I think we have to be prepared to be very dynamic and hopefully like have the best data that we can bring to bear, even if definitions change or even if the approach changes, to be able to test those. But we can predict things which are not current today. Like if a killer, not a killer, but an amazing diagnostic test becomes available that allows us to provide targeted treatment, that will be fundamentally new, not something that we would have data to be able to address immediately. Thank you.
Right. I would like to now welcome to the podium Diane Holder, who is President and CEO of UPMC Health Plan, to offer some closing comments. And you have quite a challenge ahead of you.
So thank you really for a wonderful talk. It really, I think, crystallized in so many ways, so many of the struggles we all think about as we're trying to approach how do you really change care delivery, really make an impact. This lecture, named for Ann Sonis, has been really to try to bring together thought leadership and ask the really, thought-provoking questions and issues. I've had the privilege for a very long time to be here at UPMC, University of Pittsburgh. And to me, there has been this dream for a very long time, which I think I heard a lot of similarities in that sort of glimmer of what you're trying to do at Kaiser. This concept that you can use through a large delivery system, also bring some of the better scientists in the world together, facilitate a dialogue, and then use the technology in a really transformational way. How do you bring those pieces together? And I did love your 3 words of science, technology, and culture, because I keep tripping on culture. I think we've got great science. I think we've got great emerging technology, but in so many industries, it's not just healthcare, right? But we trip on ourselves a lot. We can't figure out how to align. Cooperation isn't part of the human DNA, as far as I can tell. I mean, it's a very difficult environment in general. And the issues that you mentioned that have to do with what have we experienced the last, through the pandemic and all these other, challenges with the cost culture. So I really think that it's true that we have to keep having hope. I think hope is an incredibly important thing. I think there's a lot of reasons for hope. I think you've got voices, you've got people talking, you've got people kind of coming to the table, you've got ways you can show things work. And you really have to actually figure out how you're going to incentivize that. Because in the same way you talked about, a best practice, we don't actually know how to figure out how to get people to produce a best practice. Well, I've worked on the plan side for many years after I left our provider world. And we don't know how to incentivize properly. We don't know how to pay for the right things. We don't know. Exactly. So we have these sort of rough approximations all the time to what should matter or what can happen, and they are often contradictory. And so the very thing you think you're hoping to try to achieve turns out that it's too complicated, it's too complex, it's too difficult to implement. You sort of die in the process of from a great idea to an implementation. And so I guess what I think is that the alignment across so many of the opportunities that you mentioned in the country, people coming together, really trying to put pieces together, make a huge difference. And so I just want to say thank you to you and for the great work that you're doing, the people here at the University of Pittsburgh are doing, and really around the country and the world, trying to figure some of this out. And I think we all have to stay very, very hopeful. I've always said, why does an academic medical center want to own a payer? And I really think that's why. I think the why is you have some of the best science, some of the best opportunity to implement, and really some of the levers that you need in an incentivized payer system. And when you could bring those together, you would stop being a car on the on the lawn in parks, and you'd put it together and you'd really be able to go. And so that's my hope, that the work that you're doing will influence us and we can help influence you. And the work that everybody in this room is doing, which is exciting and I think wonderful, will really be important going forward. So I'm grateful that we had this opportunity to partner with the School of Public Health and Julie, who's amazing. The Wolf Center, the Center for High Value Healthcare, which we created at the health plan many years ago, because we could not figure out how you'd get a payer and provider to do much together in the space that you needed to. So thank you to all of you for that opportunity. And I also want to thank many of the people who are responsible for this coming together today. Gina Snyder, Mike Friend, Cindy Liberi, and Dawn Ikas Beam. You've all been wonderful and very helpful. So thank you again, and come back next year to this lecture. It's always full of thought-provoking ideas.